Istanbul, and this peripheral workshop will be facilitated by me and my close friend Nihat. We are both cardiologists. Beside complex coronary intervention, we have a lot of peripheral interventions. Also, our cath labs are loaded with a lot of peripheral interventional cases. So, for the last 3 years, I have been doing more peripheral cases than coronary cases, except coronary CTOs. I would like to thank Medtronic and especially AstraZeneca to give us the opportunity to share our experience with you colleagues from different countries. So this is not a lecture course. We want you to actively participate, and I'm sure there are things we are going to learn also from you. And also do not hesitate to ask and intervene during the program. I am going to give you a short summary of what we are going to do in these 2 days. So the program flow is like this, and I am now going to do the introduction part. It will take 10 to 15 minutes. And here is the day. That was day 1 program, and our first presentation will come from Nihat. The aorta iliac lesions will be our first presentation, and for me is the most experienced peripheral interventionist in our country. I like doing aorta iliac interventions very much. However, Nihat has done over 80 Lurish cases, just Lurish cases so far, so I let him do the presentation, albeit unwillingly. I like also doing aorta iliac lesions. So I will just give you an example what I've done 2 weeks ago. This is a Lurish case I have done 2 weeks ago. It was a very difficult case, and it was very difficult to puncture both femoral arteries. So I had to use the radial artery and go down and then puncture the femoral arteries. And here is the result after the Lurish case, after the intervention. We managed to solve the problem. Here you can see without any branch loss. It was very lucky for us. The patient rest pain alleviated considerably. So Nihat will give you a lot of examples, case examples regarding this Lurish cases and the aorta iliac lesions. So then comes my turn. I'm going to share with you the FEMPOP region intervention. I am one of those operators who advocate the endovascular first approach in FEMPOP lesions. The main problem in endovascular intervention, as you know, of this region is the restenosis and the reintervention rates. So our approach in FEMPOP intervention is to revascularize the limb with the most efficient techniques and stabilize the region with durable, long-lasting solutions. And we will also have a long talk about that. I have prepared a live and box case for you. I have a lot of live cases prepared for you. This is going to be presented as a FEMPOP case. Then, of course, during the region intervention, the FEMPOP region intervention presentation, there are certain regions that are very important. For example, the common femoral artery is a very special zone where surgery and atherectomy is very popular. So we will talk about the endovascular approach of this region, and then the popliteal artery, as you know, is another region where we have to deal with the region very delicately. So the endovascular approach in this area will also be discussed. Then, of course, we have the issue of drug-coated balloon usage. I have combined these 2 presentations into one presentation because if you talk about FEMPOP intervention, you cannot skip the issue without mentioning drug-eluting balloon because it's like a standard therapy in the FEMPOP lesions. So I have combined these 2 presentations into one. So the latest meta-analysis give us the way also for the endovascular first approach in FEMPOP lesions. So we have also scientific evidence that endovascular first approach can be very safely done in FEMPOP lesions. I will also talk about that. Then we have the carotid artery stenting issue, the carotid artery stenting treatment. I will discuss with you how to select the patients and treat by following sound scientific evidence. I have a very simple, effective, and shortcut solution in selecting and treating the patients. I will share it with you. So I will give you also some general information about the carotid artery disease. This is the boring part, of course. And the definition of symptomatic and asymptomatic patients will also be discussed, so because this will lay the path how we treat the patients in carotid artery stenting. So of course I have a live unboxing case. Then comes Nihat turn. He will talk about the basic techniques in carotid artery stenting, telescopic, standard treatment like that, and the wires. And he has also some unique solutions for difficult cases. So. And then he will continue with the challenging cases, and we have then again the controversial issues in carotid artery stenting. We have controversial issues, as you know. Although we don't have clear scientific evidence, we practice CAS, carotid artery stenting, in some patients as the state-of-the-art procedure. But even though we don't have any solid sound evidence, we will talk about that also. I have a lot of examples, case examples, and live cases for you also in this. For this topic. So there is an ongoing debate about the asymptomatic patients, which will be hopefully cleared by the end of 2020. We have ongoing randomized trials that will end by the end of 2020. So the neuro-occlusion carotid artery disease is another controversial issue. Should we treat them? The guideline says no, but we have scientific evidence, also clinical evidence that we should do them. I will talk about that. And of course, should we do simultaneous bilateral carotid artery stenting? Experts say no, absolutely not. So do we have proof? We will talk about that also. Embolic protection device is another controversial issue. Although the ACJ guideline upgraded it to 2A, we don't have any sound in scientific evidence from my point of view, so we will talk about that also. So the ready route is another controversial issue. We will have that also. So this is the day one, and in the afternoon we will go to the simulator and we will do some cases also there together. And tomorrow's program is as follows. I will do the opening with the first presentation, indications for EVAR and TVAR, and 3 criteria should be fulfilled in order to repair an abdominal aortic aneurysm by means of endovascular intervention. The first criteria that should be met is when to intervene criteria, and the patient should be at high risk for surgery. We are doing cases that are not at high risk for surgery, but one of the criteria is important, that the patient is at high risk. So, and the last but not least, the aorta should also be anatomically suitable for endovascular repair. We will go case by case, and together we will measure the diameters and how to perform which case is suitable for endovascular repair and which one is not. So we have the issue of how to treat the iliac aneurysm, which is a very debatable issue, and we don't have any on-label devices for this pathology. So we have improvised techniques and improvised solutions. Maybe we can also give you some examples about that issue. Then comes the TVAR issue. This issue is also very important. We will talk and when and how to perform TVAR, and we have only a few devices approved by the FDA regarding the TVAR procedure. Valiant from Medtronic is one of those, as an excellent device. And then I have prepared 3 live cases for this session. In this live in-box cases, we will discuss step by step how to perform EVAR. Oh, yeah, these are the three cases. And then it's Nihat's turn. Nihat has done a lot of EVAR and TVAR cases. For me, he's also a master in EVAR and TVAR. So he will give a presentation about the challenging anatomies. As you know, there are also different devices you can only use in special conditions. For example, if you have an aortic bifurcation below 80 millimeter, there is only a few devices available. And he will also talk about the devices and give you some example, which device in which case. So this will also be an interesting presentation. And he will continue with the case samples for EVAR and TVAR. And for the last lecture, he will talk about the closure techniques. He has also a great experience in closure techniques in EVAR and TVAR, ProStar, Foglite, and I told him, and he said that he will mention these closure techniques in his presentations, and he will combine the three presentations into one. So I think it's now Nihat's turn, and we will continue with aorta iliac occlusions and stick to the program.